Good afternoon, everybody. Nera Agabiti, Department of Epidemiology, Lazio region, with Marina Davoli and many other colleagues who are now present and participating in our today event. I am involved in the EasyNet project. So on behalf of the research teams of EasyNet, I would like to thank very much again Jeremy for giving his time, sharing ideas, help us in our work, and giving also the opportunity to know his Meta Lab and the opportunity to participate. So thank you very much. It's my pleasure to guide the discussion in this part of our event. And as Marina already explained, we have prepared in advance a number of questions from the research teams in EasyNet. So let's start with the first critical point, the first question. The focus is on availability and awareness of health professionals in primary care. One of the major difficulties we found during the activities in our region, Lazio region, was the participation of general practitioners, family practitioners in the Audit Feedback initiative. In general, they are quite independent in our region, in Italy. And we have difficulty in engagement, in their participation, and in obtain from them sharing protocols or processes with other healthcare professionals. In our case, because of this difficulty, sometimes or often we have to promise and give them incentives, economic incentives. In this case, in our case, we were forced to modify our original study design, simplify the methodology. So our question for you, Jeremy, from our team in Lazio region is, what is your experience with this kind of healthcare professionals? How can we increase the participation of general practitioners? Do you think there is a problem of training, education, culture, or economic or other form of incentives? Please, can you comment on this point?
Sure. This is a very difficult issue, and it's one of those areas where I think we can do research to understand how do we better engage healthcare professionals well. But I mean, two broad, there's a number of suggestions. One is, I think, one of the things we need to do is position audit and feedback as part of being a professional. Professionals are self-regulating. We know that it's hard for professionals to understand what their practice is because we have many, many studies demonstrating that. And so some of the issues would be, can you get professional leaders to start to articulate, this is something which is about helping us be the good doctors, the good nurses that we aspire to. Often one of the problems is that if people perceive feedback as being a big brother watching you, they will get very defensive. If we can say, this is one of the ways of helping you become a better professional. So some of the things I think one of the things you might want to explore is, how can you engage those professional leaders or professional bodies? In Canada, the Canadian Royal College for Physicians and Surgeons are now seeing audit and feedback as a key input into the CPD activities and accreditation. That's hugely helpful to us. Because all of a sudden, doctors are saying, well, how do we actually do this? So I think there's an issue about how do you use the profession to make this an expectation of this is what it is to be a good professional. I think it's also possible for the healthcare system to say, we expect you to do this. We pay physicians very well compared to many other people who are working in society. And we anticipate that they are acting professionally and self-regulatory, and therefore I actually think it's not unreasonable for a healthcare system to say, we want to know that you are, looking after your patients well. We want you to participate in these activities. I think if you went from the healthcare system without the professional, you could get into conflict. But if you can get the professional saying this and then the healthcare system saying, this is great. So I think some of those are the ways to do this. I think whenever you try and introduce something, say, across a population of family doctors, you're going to have some people who are really excited and do it, and you're going to have some people who will never open the email, never look at it. And the question really is, at one level, if we provide feedback to all the family doctors in the Lazio region, can we demonstrate a 5% improvement in performance, recognizing there'll be some people make no changes whatsoever. But at a policy level, if you could demonstrate a 5% improvement, and then we can get it to a 6 or 7 or 8% improvement, I think that would be worthwhile. And so again, I think we have to recognize that not everyone is going to respond to this well. But as long as enough people are doing it, it makes it worthwhile for a policy and a population health outcome.
Okay, thank you, Jeremy.
May I just quickly comment on that? Sorry if I jump into the discussion, but the issue is very interesting. I think there is a very common form of audited feedback already in place for GPs in Italy, I would say almost everywhere. And it has been in place for years. And it's an audited feedback almost exclusively focused on cost. So they are telling you how much you have been spending for your patient, which I think is reasonable in a way, but it reinforced the idea that audits and feedback is something watching on what you are doing rather than something that's a tool to help you in doing your job better. So it's a very complex issue. There are problems on the side of GPs and on this difficult governance with a sort of health professional that enjoy the freedom of having a different relationship with healthcare organizations. But there is also a problem on the side of healthcare organization that traditionally deals with that professional, I would say, in the wrong way.
So, so this is where it'd be nice to be with you all and have hours to talk about these things.
Yes.
One of the issues for that, I think, is about the saliency. So in CADA, we provided feedback on length of stay. And the physicians in the hospital aren't particularly, who are not the managers, aren't bothered about length of stay. They want to make sure their patients are getting well. And they, from their perspective, their patients go home when they're ready. And if someone takes an extra half day, that's fine. And so providing feedback on length of stay really doesn't stimulate change. If, on the other hand, we're able to say, did you realize that only 60% of your patients in oncology were getting thromboprophylaxis? That is something where I think you could get them interested in this. So, I mean, it may be one of the things you have to do in Italy is sort of say, this is different to the feedback you've had already. This is clinical feedback. It's trying to do things that are really relevant to you. And that, on a day-to-day basis, if you could improve, you'd feel good about yourself and about your practice and that you're doing something for your patients.
Yes, thank you, Jeremy and Roberto. The issue is very problematic, so we will need more time. And I like to go on another critical point of participation in EasyNet we have in the emergency setting. We have 2 regions with emergency setting care. So in our region, we try to carry out a survey just to know the baseline audit feedback, and we have a very, very low response rate. So the question is, how can we increase the response rate? And in Lombardia is one of the most damaged regions for COVID emergency. The research team from Milan would like to ask this question: is it possible, and possible how, to carry out a feedback program and evaluate its effectiveness in the presence of an external perturbation crisis like COVID? So just a flash on this critical point.
So maybe I could start with the COVID, because I think that's also mentioned in the Lazio.
Yeah.
COVID is unprecedented in our lifetimes. We have not experienced anything like this. I mean, from outside, observing the Italian experience in the first wave just looked horrendous. I mean, the colleagues who are there working on the front lines, I have huge respect for. And I think, one of the issues around audit feedback is people need the space to think about it, to think about changing practice. And if you're dealing with a virus that particularly we don't understand, we don't know the transmission routes, we don't know what risk we're putting ourselves in or our families or our other patients, I think it's very hard. So we've actually suspended quite a lot of work, not just on audit feedback, during this time period, because it just felt like it's unfair because the healthcare professionals are just too busy. And even the managers are also really, really busy. So I think it's really hard to think about this. Where we have done some work is our hospital wanted to try and make sure that staff were putting or donning and doffing their personal protective equipment correctly. When they did a baseline audit, they found in some wards it was only about 60%, and people weren't putting the masks on well, or they're taking things off and putting themselves at risk. And so they created, and we helped them further enhance an audit feedback system to try and improve that. And that was relevant. One of the key messages was this is how the hospital wants to protect you, your patients, and your loved ones. So I think we have to recognize that
they are too busy.
And we might put people off. But we are, we're, experiencing a second wave. I think our knowledge about COVID now compared to, say, May is very different. Certainly in Canada, one of the big issues is how do we resume, normal clinical services for oncology, for cardiology. So I think people's attention will switch. But there's probably going to have this stop go. So, if a third wave comes, we might have to pull back, or we might have to pull back a little bit. So I just think I don't want to. I know too many physicians, clinicians. I don't want to make their lives harder now by being unrealistic about what we can expect from them. But what you might do is you might be able to, and also the data you're going to collect now are very different. We know for cardiology that patients with heart attacks haven't come to the hospital. So if you're looking at your performance in terms of management of heart attacks, it would be very different now to where it was last year before COVID. So, but I think you can prepare. You could actually think about, okay, well, how do you develop a system that, as we come out of this wave, might be helpful. And again, it might be worthwhile thinking about what's going to be of most interest or salience to the clinicians. And I think, for example, I know that in Canada, the cardiologists would love to know more about, well, what happened to those patients who didn't turn up? Or, how did this work through? And there may be some things that, 12 months ago, you wouldn't have looked at that. You'd only looked at, say, care for hospitalized patients, but you might want to do something which would be about other aspects of care, that would be of interest to the clinicians.
Thank you, Jeremy. I don't know if you have time to answer, to give us another comment and answer, just the last one. I don't know if you have time, or do you have to leave?
3 minutes, I'm good. Okay. My wife will come and drag me out when we have to go.
So just an important point was from the research team from Turin, Piemonte. They have a key role in supporting a regional government in the field of oncology care. And the focus is on the use of routinely collected data. So they ask for what evidence from the literature, for your experience, do you have to help us in the choice of the best method for acquiring data? Only administrative data, or also adding ad hoc data sets, like in Piemonte, they use mixed forms. What do you think about it?
Yeah, the main challenge about using routinely collected data, the two main challenges about routinely collected data, one is that they're always they're normally not precise enough for clinical sensibility.
Yeah, in fact.
Okay. And so you might be able to say who got thrombolysis for their heart attack, but you might not be able to say, was that appropriate? Or did they get the other follow-on treatments for that? And then the other thing that the Piedmont group talk about is the gap. Yeah, in Canada, it takes 3 to 6 months to get administrative data. And if you're doing feedback, you're often finding data on something that was done 9 months ago. So
exactly.
you could imagine, if you're doing feedback now, you're doing feedback on what happened pre-COVID. Okay. And your clinicians would just be, well, what does this make sense of? So I think it's a balance. And so some of the issues I would be looking at is, what's a good enough indicator? Can we get that from the routine data? And I think you can say to clinicians, we know this isn't perfect, but actually it makes sense. And if you're at the end of this distribution, that's probably needs some attention, but actually thinking about what the specificity of that is. The second would be actually about the timeliness of this. If you are going to collect additional data, then I think one of the issues you might want to think about is how do you systematize that in the healthcare system so that that's done in relatively real time. So one of the groups we work with in Ontario is a perinatal and maternal health registry that provides a dashboard back to the hospitals. But they have, they've been able to provide resources to the hospital to enter data. And so they get weekly returns, and probably the turnaround is going to be in weeks or a month at most. Now, often, basically collecting data separately is done as a research activity outside the system. You have to gain access, it's difficult. I think we need to see, audit feedback and part and parcel of how systems support quality of care, in which case one of the challenges might be other ways in which you can start to make this much more part of just how routine data are collected, or data are collected routinely rather. And again, be very careful about making sure you get the data you need. We normally collect too much data that we never use, and because they're interesting, and often we find that clinicians collect data for audit feedback because they have an idea for a research project as opposed to thinking about the quality of care. So those would be two examples, but again, there's international examples. We're likely to have a webinar next year by a colleague in the US, which is talking about automating data capture and turning out feedback, which might be relevant to the colleagues in Piedmont or elsewhere. So these are all of the questions that you've given are really, really good questions, and none of them have easy fixes. None of them have, oh yes, here's something you can do and it'll fix this for you. They all need sort of, I think, ongoing work about how we can do this.